medications. Those medications, their aim is to either to prevent or to manage such disorders, to treat such disorders of the airways and the lungs. The aim of using such medications are to improve ventilation, patient ventilation, improve airway patency, and gaseous exchange. These are the goal. Any medication we're going to use to help such patients with respiratory disorders, these are the aims where we are using. So any agent that you're going to use to improve patient respiratory disorders, you must have to bring on board these important aims and objectives. You have to look whether it can improve the ventilation of that patient, improve the oxygenation, airway patency, and gaseous exchange. Once that such medications can do it, then you go ahead to give it to your patients. The scope of respiratory care, it can be found in acute care when the patient is really seriously, critically ill. You find such patient in intensive care units. They may be on mechanical ventilator or just on oxygen therapy. In chronic care, where you take care of asthmatic patients, COPD, it may be in outpatient, as the case may be, even at home. In terms of preventive care, which we still do, maybe smoking cessation, patient education is the key. Respiratory therapies, anywhere you find yourself, you must educate your patients. When they're about to go from the hospital, from discharge, in the outpatient, or even at home or in the community, education is the key. Then in diagnostics, we look at the pulmonary function test, maybe use a spirometry, ABG analysis test. As a physiotherapist, you must know how to interpret and read arterial blood gases. It's crucial. Even for us pharmacists, we can't help our patient in intensive care without knowing how to interpret ABG, because there are medication implications there. As a physiotherapist, there's still respiratory implication in arterial blood gases. Can help us to know whether our patient is having any disorder like respiratory acidosis, respiratory alkalosis, as the case may be. Even if it's a metabolic acidosis, as any other acid-based disorders, you still have to know the implications and how you're going to use to help that patient based on your own professional responsibility. So it is a must. And I hope that everybody on this call can confidently interpret ABG. It's very, very important in respiratory care. And the therapeutic interventions, when we use our medications or even maneuvers of your technical know-how as a physiotherapist, about oxygen therapy, use of aerosolized medications, you may use mechanical ventilation. They're all Hello. And airway clearance techniques, which we know that the physiotherapist does very well. So be able to know how to use such techniques to help our patients clear their airways. Respiratory care. In any techniques you may use, whether oxygenation, mechanical ventilation, medication, one is to optimize ventilation and oxygenation of our patients, to relieve an airway obstruction, prevent respiratory complications, promote health and maintenance and patient education, then support critical care and rehabilitation. Rehabilitation is very, very important. You don't just discharge that patient just like that. There is follow-up and continue support and care. And the settings I just mentioned earlier, it may be in the hospital, it may be in the intensive care unit, emergency, maybe at the outpatient setting, the community, doing the home care. The goal is to improve our patient oxygen therapy. In any way you can do it, as the case may be. I also talked earlier about the settings. You must have to assess your patient respiratory status. Okay, provide aerosolized medications. Have to educate the patients and also the caregiver. Very important. Always patients with a caregiver because it can help them to improve adherence. And you can administer oxygen or perform airway management and suctioning. Very, very important, especially patient in intensive care units. Even on the general wards, suctioning is very, very important to clear the lungs, to avoid aspiration, which can lead to death. I know it's mostly the responsibility of the physiotherapist to do that. Okay. I'm getting problem here. Hello, I've seen, I don't know what to do about it. Oh, thank God. Okay, so let's continue. Aerosolized agents, as I said earlier, we are restricting our interaction tonight on inhaled medications that we use to manage respiratory care. We can also call them aerosolized agents. They are medications delivered in mist form directly to the respiratory tract for therapeutic, diagnostic, or preventive purposes. So they can be used in either of the purposes to diagnose, for therapeutic purposes, to diagnose what is happening to the patient, or even to prevent. Okay, why do we prefer inhaled therapy? They give rapid onset of action, use it for targeted lung delivery, lower systemic side effects, can be used during ventilation. You know, during ventilation, we say near per aura in most cases. So if it's inhaled or aerosol therapy, you can easily go with ventilation. And it's ideal for chronic and acute respiratory disease. Inhaled agents don't pass through first pass metabolism. That's why we prefer it. Okay, unlike oral and some injectables, they will pass through first pass metabolism. This one goes straight to the systemic effect, where the effect is needed immediately and has a rapid onset of action. We have so many classes of these aerosolized agents. The first one is the mainstay, the bronchodilators. With two types here, the beta 2 agonists and the anticholinergic agents. We have albuterol, salbutamol, as beta 2 agonists, anticholinergic, apatropium, formoterol, and so on. We have corticosteroids, we have mucolytics, we have inhaled antibiotics like tobramycin, even inhaled antiviral and vasodilators, expectorants like a hypertonic saline. Basically, we're going to restrict our interaction here. It's going to be somehow repetitive because when we talk about adrenergic beta 2 agonist, purely on that. When we talk about vasodilators, we are still going to speak about them again. When we want to discuss medication for asthma, we're still going to talk about bronchodilators. We're going to repeat them. And I think that will help us to really get good grasp of these agents. Delivery devices, because they're aerosolized medications, we don't give them through oral or injectable. We use MDIs, we use a ventilator in our aerosol system, can be through, nebulizers. These are the devices we can use to deliver such aerosolized medications to our patients directly into their respiratory tracts. Why do you prefer nebulizer? They're very easy to use, stable for all agents, but they are time consuming, and there's a risk of contamination if not cleaned. So you can see the albuterol inhaler, the salbutamol ampoule they can use for nebulization. You can see the inhaler, somebody using the nebulizer with a mouthpiece. These are the ways that we can use to deliver those pharmacological products to our patients to improve their oxygenation and help to manage their respiratory disorders. We can use them for asthmatic patients, COPD, pneumonia, cystic fibrosis, any respiratory disorders. We can use such devices to help such patients. Now, let's start with adrenergic agents. Remember, we are restricting ourselves to inhaled ones. There are other adrenergic agents that can be given parenteral. It's above the scope of our presentation tonight. So their mechanism of action, basically, they stimulate beta-2 receptors, thereby bringing on board bronchodilation. Beta-2 agonists, they bind to beta-2 adrenergic receptors on airway smooth muscle, which triggers a cascade of events leading to muscle relaxation and bronchodilation. This process involves activating the GS protein, which stimulates the adenine cyclase to increase intracellular cyclic AMP. Then the elevated CAMP activates the protein kinase and other mechanisms, which reduces intracellular calcium levels, ultimately leading to airway smooth muscle relaxation, which will bring bronchodilation. So these are basically mechanisms of action of beta-2 agonists. But in summary, they stimulate beta-2 receptors and thereby causes a bronchodilation, leading to airway smooth muscle relaxation. Alpha-1 stimulation will cause nasal constriction, increase mucociliary clearance. The routes we can give, as we said, through inhaled routes. That's basically what we're talking about today. The first one is short-acting beta-2 agonists, long-acting beta-2 agonists, and ultra-long adrenergic beta-2 agonists. They can be given through oral, IV, and so but we are restricting our discussion to just the inhaled and also in nebulization if possible. As I mentioned earlier, Sabada is the short-acting beta agonist, beta-2 agonist. You have your albuterol, salbutamol, as the case may be. We use it in acute care, in emergency, in acute attack to rescue that patient. We prefer to use this short-acting beta-2 agonist. Then for long-acting beta-2 agonists like sameterol, we normally use them for maintenance doses to maintain the patient, even for preventive management. Then for ultra long-acting beta-2 agonists, it's basically used for COPD patients. Then the non-selective adrenergic like epinephrine, that's adrenaline, we can use them in acute attack. The alpha adrenergic like a phenephrine, we use it for nasal congestion, though we're not really looking into that one. They also use it for clinical use in managing asthma, COPD, acute bronchospasm, and so on and so forth. Okay, there are side effects. So, as professionals, as you're managing your patient with these medications, you should bear in mind the side effects that may occur. and get prepared to know what to do when such side effects happens. And patients should be educated to be aware that such side effects may arise. And they should be educated, especially when they're outpatients. That's when you see such a thing, please call. Drop your phone numbers. If you don't have your phone number, they can come back to the hospital. Patient education is very important. But when they're in the hospital environment, then we healthcare professionals should watch out for these side effects. Based on the medication you're giving to your patient, you should know that these possible side effects that may occur. And when that was in error, we must have to make an intervention. For these adrenergic agents, they can cause tremor, tachycardia. Patient with a very good heart rate, you can see heart rate going up. So you should be able to know that because of these adrenergic agents, can cause palpitation, headache, then hypokalemia when you give these beta-2 agonists in high doses. These side effects are very, very important. Not that you know that your patient have an issue with respiration, there's need to improve the respiratory, okay? We are going to use the nebulizers, we are going to use this to clear the airway, do this and do this. You bring your albuterol. Is this kind of therapy, as a healthcare professional, you must know your patients. You're not just coming to the world to come just open the airways, clear the airways, give albuterol, do this and do that. You must know that patient history. You must be acquainted with your patient labs on daily basis. Okay, so before you start your therapy as a physiotherapist, look at your patient history, update yourself. Are there recent laboratory results that are ready? You look at them. If this patient will be managing him or her of a hypokalemia, potassium was around 2 or even 1.9. Then albuterol should not be your best choice to manage that patient's airways. Because even if you're going to use it, you should be very, very cautious on the dose you're going to use, because high dose of albuterol, salbutamol, can worsen that patient hypokalemia. Okay, but if you look at the patient's electrolytes, okay, potassium was even battling hyperkalemia. Wow, then shoot your albuterol to help to reduce the potassium. So healthcare management is holistic. So the bottom line is this: you must know your patients. Know your patient means in your assessment, you should be able to be acquainted with that patient information, both subjective and objective. By subjective, I mean I'm talking about what brought the patient to the hospital, their chief complaints and everything. Then the objective aspect, the diagnosis from the physicians, the laboratory result, even the medications that are taken. So you have to look into all of those because yes, we can use this medication, this inhaled medication to manage this airway. No, we cannot use this. So those informations will now help you in your assessments and in your intervention as a physiotherapist to manage this. Let's see, it can cause arrhythmias. So we should get acquainted with our patients. And we should be very cautious. Can cause uncontrolled hypertension. We should be very cautious when using adrenergic agents in our arrhythmia, thyroidism. Infants, we're going to talk about the pediatric consideration when giving these inhaled agents as we go on. We can get them in combination, mostly found in combination. You can have inhaled corticosteroid with long-acting beta adrenergic agents. You can have short-acting beta adrenergic agent with short-acting anticholinergic agent, and as the case may be. The pediatric note said that weight-adjusted dosing very important. You don't give the same dose you give to the adults. So once you're taking care of the pediatric patients, you must adjust the dose based on their weight. We prefer to use nebulized short-acting beta-adrenergic agent is preferred for the pediatrics and will continue to monitor their heart rates and tremor. Very important. Don't just administer your adrenergic agents, do your airway technique maneuver and just go. You have to monitor your patients, especially heart rate and tremor, mostly in pediatric cases. Now, let's talk about the bronchodilators. As I said earlier, we will be repeating beta-adrenergic agents, anticholinergic, as the case may be. You can't talk about respiratory care without talking about bronchodilators. Okay, the inhaled agents delivered through the aerosol or dry powder inhalation to relax the bronchial smooth muscle. Okay, and the airways, as the case may be. Why use inhaled bronchodilators? Bronchial smooth muscle relaxation, they cause direct local effects, minimize systemic effects, very, very important. So that's why we always use bronchodilators. Still, bronchodilators are made up of our dear adrenergic agents, the short, the long-acting, ultra long-acting, short anticholinergic agents, long-acting. I can get it in combination therapy. These things are called bronchodilators. The adrenergic agent, the anticholinergic agent, then they dilate the airways. I've already talked about the mechanism of action of a beta 2 agonists, what they do and how they dilate the smooth muscle relaxation causes. Then for the anticholinergic agents, they block M3 receptors, thereby causing bronchoconstriction. We all know what acetylcholine does, muscarinic receptors. So these agents counteract their effects. Okay, what do they do? As I said, they block the action of the neurotransmitters, acetylcholine, prevent it from binding to the receptors, inhibits the parasympathetic nervous system, leading to effects like reduced involuntary muscle contractions in the lungs, GI, and even the bladder. They block the receptors, act as competitive antagonists, blocking acetylcholine binding to muscarinic receptors, both in the central and peripheral nervous system, relaxing the smooth muscle in the airways, decrease glandular secretions, leading to side effects like dry mouth, reduce sweating, blocks the action of acetylcholine neurotransmitter, okay, and trigger muscle contraction. That's bronchoconstriction. So these are the mechanism of action. That's why they can cause dry mouth. So in this case, you must have to hydrate your patient because they block the effect of acetylcholine. Home bronchodilator, as we said earlier, the short-acting beta-adrenergic agents, they are salbutamol, albuterol. They act up to 4 to 6 hours, though they have rapid onset of action, but their effect lasts at most 6 hours. We use them for rescue therapy, acute attack. Then for short-acting anticholinergic agents like ipatropine, that they can act above 6 hours. We add them on to adrenergic agents. Then the long-acting beta-adrenergic agent like formoterol, they can last for up to 12 hours. We use them for maintenance doses, and even in preventive management. You can still combine them. Here, this slides, I try to compare the anticholinergic agents and the beta-2 agonists. In terms of onset of action, beta-2 agonists act very fast, unlike anticholinergics. Mechanism of action, we know that anticholinergic blocks muscarinic receptors, while beta-2 agonists stimulates beta-2 receptors. We prefer to use anticholinergic in COPD and the beta-2 agonists in asthmatic patients. Remember their side effects. Anticholinergic mostly dry mouth. But for beta-2 agonists, tremor, tachycardia, hypokalemia, and the rest. We still deliver them through the same way: meter dose inhaler, dry powder inhaler, jet nebulizers, and so on. We use them to manage this kind of issue. Whether the patient is mechanically ventilated, you can use these bronchodilators. We've already talked about their side effects. Tremors is for anticholinergic agents, dry mouth, anticholinergic, and then tremor, tachycardia, hypokalemia, when you give excess of beta-2 agonists. These slides, I just try to bring out the pediatric dosing for these bronchodilators. Salbutamol, patient age less than 5 years, give 2.5 milligram salbutamol nebules. Prefer to use spacer plus max is optional too. It's for adult ICU, prefer to use up to 2.5 milligrams salbutamol. May add it with ipatropine. Always monitor airway pressures. So this is just basically standard dosing. Remember, I said for pediatrics, age/weight-based dosing, very important. Just a little case study to portray what you've already heard so far. This first one, adult ICU patient, 8-year-old male, had COPD exacerbation, ventilated, treated with salbutamol plus ipatropine nebules. So you can see we have here short-acting adrenergic agent plus short-acting anticholinergic agents given together, but given every 20 minutes, 3 times, really had an effect on this patient, improved that patient's airflow, and improve the SpO2 of this patient just by using these two combinations. Okay. Then the pediatric patient is a 5-year-old with acute asthma. I was giving salbutamol using MDI and Spexa. I was monitored. The heart rate was monitored and the patient became better. So you can see not what was given to this pediatric patient was given to the adult patient. So patient scenario differs, the age and the how acute the exacerbation is, the respiratory disorder is, will now determine the intervention that should be given to such patients. And for mucoactive agents, what they do, they modify mucous properties to enhance airway clearance. So we've talked about beta-2 agonists, we've talked about as anticholinergic agents, and all bronchodilators. Now I want to discuss mucoactive agents. We can use them to manage cystic fibrosis, in COPD, including bronchitis, as the case may be. So it's still one of the agents we can use to manage respiratory disorders. How do they work? For mucolytic, this one reduces the mucus, like N-acetylcysteine. The expectorant increases water content. If you see, we're not talking about the cough syrups, no. It's just the hypertonic saline, maybe 3% normal saline. They help to increase water content and thereby help to expel those secretions from the airways. We have mucoregulators. They modify the mucous secretion. You can have combination agents of these mucoactive agents. So this slide is just showcasing the common inhaled mucoactive agents that make list of actions, their indications, and the notes. And see N-acetylcysteine, can use it to manage COPD, cystic fibrosis. There are mucolytic, breaks disulfide bonds. The notes can be irritating to airways, often nebulized with caution. Okay, let's get into hypertonic saline, maybe 3% to 7% normal saline. The osmotic agent, they draws water into the mucus. You can use them to manage cystic fibrosis, bronchokeratitis. In the notes, may cause cough or bronchospasm. Therefore, you must pre-treat with bronchodilators. So don't just go straight to use hypertonic saline. You must pre-treat with bronchodilator, which may be beta-2 agonist or anticholinergic agent first, before you can now use this mucoactive agent, especially this hypertonic saline, as case may be. These are the doses and administration. See the pediatric adjustments. You have to lower volume and concentration. You must pre-treat with bronchodilators. Very, very important. Clinical consideration. I mentioned before the airway clearance therapy. As I said earlier, you pre-treat with the bronchodilators if reactive airways. Encourage hydration, especially when you use anticholinergic agents. Monitor for cough, wheezing, irritation. Storage is very important too. Store in refrigerator, especially for Donors alpha. It's a type of mucoactive agent. This slide just showcasing the inhaled mucoactive agents. Their special node, their frequency, mechanism of action, doses, that for children or for adults. So I will have access to this slide. So go through and see how it's going to help us in our practice. So any agent you want to use, you should bear in mind the special consideration and the doses and how they work. For pediatrics, I always still maintain that you adjust the dose based on age and weight. We have so many referral books that will help us. And make use of Medscape, you can make use of MDES, so that you are sure of the actual dose for the pediatrics. And you have to start lower concentration for hypertonic saline. You monitor tolerance and airway reactivity. So as you're making your intervention, you must have to monitor the airways to really check whether what you're doing is really helping that patient or complicating the problem. The practical tips, I've already mentioned them earlier. Always to clear the airways, administer mucoactive agents, but to always insist that you pre-treat with bronchodilators, especially with acetylcysteine and the hypertonic saline. Hydration. Encourage oral fluids to enhance effectiveness. Monitoring, watch for cough, wheezing, and airway irritation. Know how you store your agents. Though in the hospital, pharmacy does that. The pharmacy does that. That's the storage. The mucoactive agents improve, that's in summary, improve mucus clearance, lung function, and reduce infection risk. Choice depends on disease, patient age, and tolerance. We are talking about individualized therapy, personalized therapy, that this is a gold standard for everybody. No, you have to look your patients into idiosyncrasy and to patient personalized issues. Okay, because yes, it may be a good time, but because of this patient, because of so issue with the patient, this agent cannot be used for this patient. So you must have to understand that before you now come to say, okay, yes, let's use this for this patient. It's essential component in respiratory care for chronic airway disease. That's mucoactive agents. So now we've talked about allergic agents, the anticholinergic agents, and mucoactive agents that are all inhaled medication we use to manage respiratory disorders. Now let's move into inhaled corticosteroids. So if we talk about all this without mentioning corticosteroid, I don't think we've started because it's a gold standard. The mechanism of action. ICS, that's inhaled corticosteroids. They reduce airway inflammation, suppresses cytokinin production, decrease airway hyperresponsiveness, which is the issue with asthmatic patients, improve lung function and symptom control. We use them for long-term therapy though. They inhibit the release of arachidonic acid through phospholipids inhibition, thereby producing direct anti-inflammatory properties in the airways. They are very, very important in managing respiratory disorders. Inhaled corticosteroids. Examples are beclomethasone, budesonide, fluticasone, and the rest. We use them for asthmatic patients, all severity levels, chronic obstructive pulmonary disease, mainly in combination therapy, for prevention of exacerbations, in pediatric patient and adult patient respiratory care considerations. So we still use them for both pediatrics and for adult patients. Their routes you can still use in all these MDIs, DPI, nebulizers, sensor device. You can use this device to administer this inhaled corticosteroids. Dosing titration, very, very important. If you look at when we talk about allergic agents, anticholinergics, so I don't really stress so much on dosing. It's just that of pediatrics. But for inhaled corticosteroid, even oral or thereby, you must start with a low dose. You continue to stepwise improve it to medium and to high dose ranges. Don't just start from a very high dose. Even when you want to stop corticosteroids, you taper the dose down. Don't just stop abruptly. It's wrong. Okay, so you stepwise titrate based on control. Start from a low dose and monitor your patient. If you are achieving your goal, then you stick on that dose. If you are not, continue to step it up. The monitoring for response and side effects. Corticosteroids have their side effects too. So all these medication we're talking about this night, they all have their side effects. So our goal is to improve our patient quality of life, improve their respiratory issues, good airways also. But we don't want to really affect them back because of that taking those medications. So as we are managing them, we have to monitor for response and also keep an eye for possible side effects. Side effects may arise by use of these corticosteroids. For local effects, you can see oral throat, dysphonia. If it's systemic use, you see adrenal suppression, growth retardation in children. For preventive measures, if you use corticosteroid for your patients, if they're conscious patients, they must have to rinse their mouth after the inhalation. It's very important information we should give to our patients, and we should expect them to do that. Special consideration, okay? We must have to monitor our patient growth monitor, especially in infants, in pediatrics, when they are using corticosteroids. For elderly patients, look at their bone health, cataract risk, because they predispose them to these problems. For pregnancy, we don't give pregnant women corticosteroid, whether inhaled or not. It's only about 24 weeks or thereabouts when there's issue with the pregnancy, maybe not yet preterm babies. Okay, so at that point, when there's problem that may make the woman to go into contraction before the term, then corticosteroids should be given to such pregnant mother from 24 weeks GA and above, just to help develop fast the lungs of the fetus so that they can easily survive when they come out preterm. And they don't give it to them a very long time because of the possible adverse effects on the infant or on the fetus. Safety profiles must be considered. You look at the risk-benefit ratio before you give any patient who is pregnant corticosteroids. They can be given in combination therapy. So inhaled corticosteroid can be given alongside in combination with long-acting beta agonists. I'm given it with long-acting muscarinic antagonists. That is anticholinergic agents. Benefit in poorly controlled asthma or COPD. If you add inhaled corticosteroid, you see a very good benefit for such patients. Clinical evidence from researches, studies, literatures, we found that inhaled corticosteroid reduces exacerbation frequency. And that's the goal. To improve our patient quality of life, we don't want them to be having such attacks. Okay, so corticosteroids help to reduce the frequency of exacerbation. They improve lung function and quality of life of patients. Very, very important. You see children who are having respiratory problems, they go to school, they'll just stay one corner, they will not play, nothing, their quality of life, they're depressed. But inhaled corticosteroids really helps to improve patient quality of life. Look at the guidelines, GINA asthma and GOLD COPD guidelines. You see what corticosteroid does to such patients. In summary, inhaled corticosteroids are the cornerstone therapy in chronic airway disease. For airway that's long for a very long time, it's a cornerstone therapy. Remember, not just for rescue attack. That one we prefer to use beta 2 agonists. That's safe, effective when used properly. Monitoring and patient education are very, very essential because all these agents have their own considerations, monitoring and educational issues that we must have to let our patients and the caregiver know as we give them such medications. Now, we have to look into anti-asthma because when we talk about respiratory care and we didn't talk about asthma, it's like you've not really finished well. It's I'm restricting now this discussion on inhaled market because there are so many anti-asthma medications that I'm not going to mention tonight. It's above our scope, like promonine, leukotriene modifiers, so many theophylline, malizumab, and so on and so forth. I'm restricting this to just the inhaled ones. And as it may be, we've already talked about them because they're basically beta 2 agonists, anticholinergic, and so on and so forth, even corticosteroids. But let's just briefly look at them again. Inhaled anti-asthma medications are the cornerstone of asthma management. The advantages are rapid onset, high lung concentration, reduced systemic side effects. You can still deliver them through all these delivery methods, as we've talked about earlier. You know, the most important thing here is there is hyper responsiveness. The arterioles, there's inflammation. mucus, blocking the airways. So the goal is to open the airways, reduce the mucus, reduce the inflammation so that the airway be patent, that a patient can breathe and there is enough gaseous exchange. So that is the goal. So any agent that can help us to reduce inflammation, reduce mucus secretion, and reduce the hyperresponsiveness, that agent is what we are going to talk about. That will help us to manage our, and all. The first one is inhaled corticosteroids we just spoke about. They reduce airway inflammation, reduce mucus production, and improve bronchodilation response. See this, first line for persistent asthma. If it's persistent asthma, remember I said earlier, we use it for chronic therapy, chronic respiratory care. We use corticosteroids and inhaled. So it's the first line for persistent, and that means it's a chronic issue. But remember the side effects, oral thrush, dysphonia, that we have to minimize with pencil and mouth rinsing once we are using inhaled corticosteroids. Always tell patients, always rinse their mouth after use. We still use short-acting beta-2 agonists. Oh, you know, their means of action, they stimulate beta-2 receptors, causing bronchosmosis realization. We use them for rescue therapy for acute attack. When there is acute attack, you want urgent rescue for that patient. We go straight to use inhaled beta-2 agonists. Remember their side effects, tremor, palpitation, tachycardia, even hypokalemia. Then we still use long-acting ones like salmeterol, which is a prolonged bronchodilation. Okay, we maintain them with corticosteroids. Then also we use inhaled anticholinergic agents. All this can still use to manage asthma, atropine, and so they block muscarinic receptors, causing bronchodilation and reduce mucus secretion. Okay, remember their side effect, dry mouth, throat irritation. You can use them as combination agents. They improve adherence and symptom control. So when you combine inhaled corticosteroid with long-acting beta-adrenergic agents, you now have both anti-inflammatory action, long-acting bronchodilation at the same time. Then special considerations for pediatrics. Remember our weight-based dosing, use pencils, age-appropriate inhalers. You don't use our well-known salbutamol inhaler for patients under 3 years or even under 4 years, or do not really use it very well. You prefer to use it for patients above 4 years. Elderly, focus on inhaler technique and education, technique training essential for efficacy. Also, you monitor system control, monitor the peak flow and exacerbation frequency. So just this slide is also showcasing the inhaled antiasthma medications, the inhaled corticosteroids, their types, where we use them, the key points. For anti-inflammatory purposes, we prefer corticosteroid as the first line. For rapid short duration of action, we prefer to use salbutamol. To improve adherence, you combine corticosteroids and adrenergic agents. So what you want to achieve, that means the agents you are going to use. So lastly, we're going to talk about special conditions for pediatrics in respiratory care. As a way of introduction is very, very important. Okay, even since I've been talking, I always mention pediatrics because they are peculiar. You don't manage them how you manage adults. Importance for their specific management, very important. If you don't bear them in mind and you manage them how you manage adults, a patient may be disposed to having one problem or the other. Why do we do that? There are basically a lot of difference between pediatrics and adults in terms of their physiology, in terms of their anatomical differences. Thereby, the dosage differs, the technique to manage them also differs. In case of anatomical and physiological difference, we all know that our pediatrics, they have narrow bronchioles, which cause increasing resistance. Their bronchioles are narrow when you compare that with adult patients. They have risk of obstruction because of the narrow bronchioles. They have higher respiratory rates. Like if you look at the monitor pediatric, you can see heart rate 124. We're not bothered. But if it's adult, we are bothered. Fatal rates can affect the disposition of inhaled medications. But it's not like beta blockers, what they do to the heart rates. So it's important that it's being monitored and looked at when giving them to the pediatrics. They have lower tidal volume that requires adjustment in nebulizer or inhaled dosing. They have muscles, less ability to compensate for airway obstruction or disease. Okay. Then for their physiological consideration, they have small size, which causes increase in resistance. Let's say the higher respiratory rate, immature immune and metabolic systems. They have increased risk of adverse drug effects. Very, very important. They can they are as a slight increase in above dose for this patient may cause them effects and prone them to have adverse drug effects. So we should be very careful in dosing these patients. Yeah. For devices that are going to use the same thing, they can use MDI with spacers are perfect for children to improve drug deposition. Nebulizers may be used for infants or cooperative children. Face masks may be necessary for every young children who cannot use a mouthpiece. Now the particle size of the agent, particles penetrate deeper into smaller pediatric airways. Dosing adjustment very important. Typically, don't use standard adult dosing for the pediatric. They can take all these agents we've discussed, but it depends on the dose you are giving them. You can take bronchodilators, corticosteroids, mucoactive agents, as the case may be. For use nasal breathing for this patient, due to we said that they have patients less than 1 year, they have small tidal volumes. For toddlers 1 to 3 years, they still have poor coordination, not really understand what you're telling them. So there's need for Spencer stroke marks. For older children above 3 years, those patients can self-administer if they understand. But education is the key in such patients. You have to really educate the caregiver and the child too. Delivery system, we can use metered dispenser. We prefer this in children. For infants, we can use nebulizers, one cooperative patient, severe exacerbation. For dry powder inhalers, use only children that are above 6 years. We must emphasize on the fitness of the masks, the techniques, and the adherence purposes. As I always say about the weight-based dosing consideration, very important. And after that, we must monitor for systemic side effects, tachycardia, growth suppression because of use of inhaled corticosteroids, hypokalemia because of high dose of beta-2 agonists, avoid overuse of bronchodilators. Technique and compliance. You must have to educate the caregivers because children don't really understand. The proper technique is critical for efficacy. training the children. You can use play therapy with them as you're playing, use it to play, and still emphasize on what you want them to know about the use of their inhalers. Monitor adherence. Children may struggle with consistent use. Caregiver must be supervised. For safety consideration, systemic absorption, children are more sensitive to systemic effect, so we prefer inhaled agents in this case. You still monitor these side effects. It depends on the agent you are using. Strict dosing is vital. Monitoring for them, we will look at their improved oxygenation, when there's a decreased wheezing. We use these objective measures to monitor their response, use of pulse oximetry, spirometry, if age appropriate though, then you watch out for the adverse effects. That's the monitoring. It don't stop your responsibility. You must monitor the intervention you have done. So you must have to monitor to make sure that the objective of your intervention was achieved by use of these agents. As you said earlier, for acute exacerbation, children may require high frequency inhaled therapy or continuous nebulization. For chronic condition like asthma, care plans should be individualized based on age, ability, and disease severity. If the patient is in the ICU, mechanical ventilation may require specialized nebulization techniques or inline inhaler adapter. Take on to the monitoring, depending on the age, use spirometry. If it's for long-term use of corticosteroids, you know what to look at as for the adverse effect or the side effects. Help to try response to therapy and triggers too. So we must have to properly educate them, train them the use of points of the device, importance of adherence, how to recognize signs of deterioration. Education is the key in respiratory care, because if they present earlier, they will be saved better than when they must have deteriorated before presenting. Action plans for asthma or chronic respiratory disease is very crucial. Those are the triggers, the allergen, is it cold, what predisposes such patients to such exacerbation. You look at the comorbidities, psychological, the convenient device to use. We must have minimize medication errors. As I said, let just say, hey, let me just use corticosteroid. You have to look into our patient, look at the lab result, take the medication to do your reference. That's why collaborative teamwork is the key in managing respiratory patient. In all ramifications, in all patients, it's teamwork. Because it's only the pharmacist can easily look at your patient prescription, look at them and say, okay, this is a medication error. So we must have to work together with healthcare professionals to really optimize our patient outcomes. Appropriate inhaler is very important. Correct device, correct using, appropriate monitoring, education, and adherence are central to effective care. I have 2 case studies. Let's still continue. I have just 2 case studies to portray what we've been discussing for over 30 minutes now. Bye, go ahead.
I think you should be rounding up. You should be rounding up, Dr. Waf, because already past 8.
Okay. Beautiful.
Thank you.
It just said, let me just go through the case study. I mean, I'm not really talking much on it. This is a patient, this is a pediatric patient, 8 years old male, weight 28 kg, medical history, recurrent wheezing episode since age 5, diagnosed with moderate persistent asthma, no other chronic illness. Current medication is occasional short-acting beta agonist inhaler. So if you see such patient, they presenting complaints, increasing coughing and wheezing for over past 2 weeks. Nighttime awakening due to breathlessness twice weekly, difficult participating in physical activities at school. That's poor quality of life because of this respiratory issue. Clinical findings, the heart rate is 102 beats per minute, respiratory rate 28 beats per minute, BP 9860, physical examination, there was respiratory wisdom in both lungs, miles of accessory muscles, spirometry, C, FEV1 70% predicted, FEV1 stroke LVC ratio 0.75. So assessments, I would have loved to stop the other slides and see what people can tell, but since we don't have time, let's just go straight. You can see that it's a real persistent asthma exacerbation. The triggers are seasonal allergies, viral upper respiratory infection. Treatment goal for this patient is to control the symptoms, prevent exacerbation, and improve lung function and quality of life. You can see, you just sit at school, you don't do anything, there is no, so we must have to do something to help this patient. So the pharmacological intervention now here is to use inhaled corticosteroid, like fluticasone 100 mic twice daily, short-acting beta agonists like salbutamol as needed for relief, quick relief. The delivery method may be metered dose inhaler with spacer because it's a pediatrics. The rationale, you can see the rationale. I will not continue to read it. Corticosteroid will reduce airway inflammation and prevent exacerbation. The short-acting anticoagulant, beta-2 agonists, rapid relief of bronchospasm, dispenser enhances drug deposition in the lungs, reduce oropharyngeal side effects. Then, because it's a pediatric, we prefer to use proper inhaler techniques, adherence, and monitoring. Then the follow-up must be there. You will look at the clinical echo, symptom diary, check about the nighttime awakening, school activity tolerance. After 3 to 6 months, you check use spirometry to check what is happening, whether there is improved lung function. Okay. Then the side effects, because using corticosteroids, check out for oral candidiasis, education on inhaler techniques and triggers. So after 4 weeks, you find that there is reduced coughing and wheezing, no nightmare awakening again, improved physical activities and tolerance in school, and FEV1 improved to 85% predicted. So our patient became fine. Key learning points: inhaling pharmacotherapy is central in asthma management. Correct technique and adherence are crucial in pediatric patients. You have to combine corticosteroid and diuretic agents, then you monitor the lung functions and side effects, ensure safety and efficacy. This is an adult patient in the ICU. He says he's 5 years old, male. Medical history: had chronic obstructive pulmonary disease, has hypertension, weight-related, smoked 40 packs a year, was not ICU admission because of acute exception of COPD with hypercapnic respiratory failure. So in this patient now, there is severe dyspnea and productive cough, there is wheezing, the sputum, there is fatigue, and he's confused due to hypoxemia, and oxygen saturation is just 85% on room air. So bearing all this in mind, the clinical findings for physical exam, there is diffuse wheezing, prolonged respiratory phase, sensory muscle use, cyanized. Then investigations, okay, you have to look at the heart rate is 112 beats per minute, BP 140/85. Then you can look at the ABG results. PO2 is 58 milligram per mercury. PCO2 is 66 millimeter mercury, and pH is 7. So looking at it, what do you have to say? It's respiratory acidosis though. And the chest X-ray, that's in hyper-inflamed lungs, no consolidation. He's in the ICU for respiratory failure, COPD exacerbation. He has a risk factor of smoking. Treatment goal is to improve oxygenation and ventilation, relieve bronchospasm, prevent complications. So the pharmacological intervention here now, first you start with bronchodilators, short-acting beta agonists, salbutamol via nebulizer every 4 hours, with short-acting anticholinergic agent, ipatropine bromide via the nebulizer every 6 hours. And this for systemic therapy, maybe IV corticosteroids. Then oxygen therapy titrate to maintain SpO2 90 to 94%. Very important. And the rationale: the short-acting beta agent will cause rapid bronchodilation, reduces airway resistance. Short anticholinergic agent will cause bronchodilation for synergistic effects. Nebulized therapy is preferred in ICU for critical ill, ventilated or uncooperated patients. Corticosteroid will help to reduce airway inflammation and improve lung function. So the monitor in ICU continues to monitor the SpO2, heart rate, ventilator setting, the ABG every 6 to 12 hours. The side effect, remember the side effects we mentioned, you look at those ones. Steroids can cause hyperglycemia and so on. Then mechanical ventilation, prepared if PCO2 rises further. So if it's continued to rise, there is need to intubate such patients. It's the outcome for this patient after 48 hours. I was found to have improved oxygen. HPO2 was improved to 92 to 94% on low flow oxygen. I was reduced wheezing and axillary muscle use. PCO2 was decreased to 55 Newton mercury. pH normalized, patient stabilized, and transferred to the general ward. Key learning points. Inhaled bronchodilators are essential in such acute patients in ICU. Combination of adrenergic agent and anticholinergic agent enhances bronchodilation. Nebulization is preferred for critical ill patients. Close monitoring of vitals and ABG is critical for ICU pharmacotherapy. Early intervention reduces ICU stay and improves outcomes. Our role as physiotherapists is to educate or devise techniques, evaluate response, prevent equipment contamination, administer emergency therapy, adjust medication system delivery. The takeaways. Respiratory care is a specialized healthcare discipline focusing on assessment, treatment, prevention, and education. Provide in acute, chronic, home, and even in community setting. Respiratory play a critical role in patient outcome. And important, this role should be done as a multidisciplinary team and outcome for our patients.
I'm not
Thank you
locking
so
the door
much
yet.
for listening.
I have things to carry.
I'm done.
Thank
Thank you.
you. Thank you.
Thank you, Ma. Well done.
Nice having
I cannot hear you.
Thank you, Ma. Thank you so much, Dr. Nwa for Maureen. Thank you for this robust section. And it was very enlightening. And you all can actually attest that as a physiotherapist, pharmacology is the key principle of whatever we do as a physiotherapist. And at this point, we will take questions, comments, and contribution. So I can see if you want to actually ask your questions, you raise your hand using the favorite emoji of you can see you can see on the screen. Raise up your hand and I will call out your name so I can actually ask your questions. So Dr. Charles Ogo, please can you unmute yourself and ask your question? Okay, I think we lost him. Please, if you have any questions, you can actually indicate by raising up your hand. Okay, Dr. Nelson Oli, please, can you actually unmute yourself and ask your question? Thank you.
Okay, thank you very much, dear presenter. That was a very, very interesting presentation and very insightful. Actually, as you were presenting, I was like, wow, if we as physiotherapists will be in a position to do all these things, that would be a very great advancement in our practice. Now, but my challenge is considering the environment where we work. I was expecting to see a kind of relationship between us, the physiotherapist, and the pulmonologist or respiratory intensivist that work in the ICU, to see the role we play alongside with them, because it might really be very difficult for most centers to allow us to prescribe some of these aerosol and manage the patient directly. Talking from my own center where I work. So I don't know how feasible or how realizable it is for us to get to this level where as physiotherapists will all be allowed to, to work at that level. I don't know if you have something to say to that. Thank you.
Thank you so much, Dr. Nelson. And please, Dr. Morin, can you respond?
Okay, great. Thank you so much for this question. Though always discuss based on my own setting. And I work in UNTH. And I work in ICU, and in that ICU we have physiotherapists working with us. And I always see them asking us for salbutamol, nebo, this and this, this and this. We give them, they prescribe, we give them. So all healthcare professionals, we have our roles we play. So as a physiotherapist, you don't need to be the physician to prescribe albuterol, prescribe salbutamol nebules for you to use to nebulize your patient before you ask for it. No. Everybody, we have our own different roles. So in my own institution, physiotherapists will come, assess the patients, write in the folders what they want to do, and ask for the medication they want to use for such patients, and we give them. So, but here in Nigeria, we don't really have that, like this person is a physiotherapist, this person is the respiratory therapist. No. Here in this country, physiotherapy does all those responsibilities, unlike what happened in the Western world. So, but all settings should allow different healthcare professionals to really work as they should, considering their own responsibility. As a pharmacist, I can't just though, like as I presented, for example, partly with hypokalemia for this patient, and if therapist is asking me for salbutamol or albuterol, I will still remind him, remember that he's having hypokalemia, but it's just my own personal advice or contribution for such patients. But physiotherapists should know the best agent to use to manage his or her own patients. So that's how we practice in my own center. Answered your question?
Yes, thank you very much. I think for that to be visible there, I wouldn't know how they were able to get to that setting. I actually work in Federal Medical Center here, and I know where I work, even in the ICU, we are not allowed to make such prescription because anything that is outside physical maneuvers, the medical doctors, want to be in charge and all that. Except if we're having a different orientation right now to see how can engage them in discussion, probably if they can buy into the idea. I think that's one of the takeaway from this presentation. And if we make some suggestion that, look, we think that this patient might benefit from salbutamol, and like you mentioned, considering the side effect too, and if we're able to discuss with them intelligently, probably they can allow. But as it is right now, it's not been a very normal practice in my center.
I want to. I want to let you know that you have to start from somewhere. This is. Don't know why this is. I'm hearing echo. What's the problem, please?
You can continue, ma. You can continue, ma.
Okay. You must have to start from somewhere. Previously, in my own center, we pharmacists were not found in intensive care units. We have a cubicle somewhere, we dispense, give the nurses, they will take it. We don't enter the ICU. That's what was happening in UNTH before, prior to 2013, 2014. Before we went for training and come back and change the status quo. Pharmacists are in the intensive care unit 24/7, managing patients along with other healthcare professionals, likewise physiotherapists. We are seen there 24/7. So everybody knows that we are all working together for these patients, and everybody is respected. We have our seminars together. So start from presenting to the multidisciplinary team in your intensive care units the role of physiotherapists in the ICU. Start by presenting, start by doing it. Let them see the results. If you have, start by bring in that data. You publish your work, before you know it, you become visible, start to respect you, allow you to do your work. Nobody will call you. It's you that will tell them who you are. In we are there 24/7.
Since like we lost Dr. Maureen, like she was saying, information is key. If you know, you know. If you don't know, you don't know. So now, I can also attest to the fact. Okay. I think one of my very big guys is actually on the line. Please, Dr. Onwubere, please, can you actually unmute yourself?
Yeah, thank you very much. I'm not going to talk for a long time because the meeting has
Thank you,
lasted.
Prof. Thank you, Prof. Thank you, Prof.
Meeting has lasted a bit longer than.
Sorry. As I was saying,
Dr.
from
Murray,
somewhere.
Okay, Dr. Murray, 1 minute. Professor Onwubere is on the line. Prof, please, can you?
Yeah, you can see a good number of people already leaving. So I'll be very brief with my comment.
Okay, Prof.
And it's in line with what Dr. Nwafor was actually saying before. And somebody asked a question about what he was not allowed to do in his center. I'm quite surprised about that. Practice of medicine is multidisciplinary.
Yeah.
There's need for teamwork. We did that. So Dr. Nwafor was referring to that from 2013 or something like that, when I was chairman of the National Cardiothoracic Center. We all made it obvious that everybody is needed in the health center. I don't even think anybody should claim it's more important than the others. We use open heart surgery as an example, which many were done at the University of Nigeria Teaching Hospital years ago. Everybody is involved at every stage. From the patients go to the cardiologist, they work them up, decide they need surgery, and the meeting is called of all the health workers inside the center to decide when the surgery will be done, whether the patient actually needs surgery. In the theater, it's multidisciplinary. The nurse is there, the surgeon is there, the perfusionist is there, the cardiologist is even there doing echo while the operation is going on. Once the patient comes out, goes to the intensive care unit, the nurses take over. The physiotherapist must believe the physiotherapist is not there. This patient will not recover, will not start breathing properly. If the pharmacist is not even there, supervising the drugs, pre-operatively, intra-operatively in the theater, in the intensive care unit, that patient will not survive. If the medical lab scientist is not there running tests, they start running tests inside the theater, run even after until the patient is discharged. So everybody is in the health sector. There is job division, quite all right, but the aim of medical practice, as is done in developed countries, is multidisciplinary, and everyone is important. There's nobody that say, I'm in charge of this. Well, somebody may be at the center controlling it, but that does not mean that that person will do everything for one patient. So this is one thing we learned from this lecture. I must thank Dr. Nwafor for this very good lecture. I wasn't surprised. I've known her for many years. But it's very, very, with the learning point is there for all of us to learn a lot. It's not only physiotherapists, which is probably the main center of this organizing this unit, but then everybody who attended this meeting benefited from this lecture. Thank you very much. Thank you, physiotherapist Mosu, for organizing this, and all those who participated in one way or the other. Thank you very much.
Thank you, Prof. Thank you, Prof. Thank you,
Please,
Prof.
moderator, please permit me to recognize my mentor, Professor Basino Onwubere. I didn't even know that he's on this call. Prof, thank you. He's the person that made me who I am. My training, everything was when he was our chairman of our center. He's a father. If you want to be who you are, he will help you. Even took me to Mozambique to make a presentation, paid everything, fly. In short, Prof, I'm highly indebted to you. God bless you. May God keep you for us in Jesus' name. Amen.
Amen. Thank you very much, Dr. Wafo. God bless you as well.
Thank you so much. Thank you so much. Thank you so much. And thank you, Prof, for joining us. Thank you once again. And then I also have to actually thank each and every one of us for staying to this very moment. Like our standing tradition, the group will still be open for comments and contribution. Drop your questions. Dr. Moren Wafo will still be in the group to actually respond to all the questions. And then now, okay, my very own chief is online now. Chief Ezinenwosu, can you say one or two things for us before we close? Okay, she's now responding. I think at this point we've come to the end of this. Okay.
Thank you.
Look at today's presentation and lecture. We will continue the remaining lecture in the groups. So just drop. Feel free to drop your comments and contribution. We'll respond to that as soon as possible. And then the lecture materials, the recordings, and the recordings will be available, made available to each and every one of us. Thank you, and God bless you. Have a good night rest.
Bye. Thank you. Good night.
Good night, everyone.
This month, yes, so what if you guys be doing her? It was like a side play. No. It's actually for the type. Come I met or the two multidisciplinary. So we got some people from the group. So